Hello and welcome to another episode of the ABIP podcast. This is Abhinav Agarwal, your host from the Zucker School of Medicine at Hofstra Northwell in New York. The views expressed in this podcast are those of the speaker alone and not necessarily those endorsed by the AABIP. Today, we have the pleasure of hosting Dr. Francisco Almeida to discuss tips and pearls on the role of electrocautery snare in the management of malignant central airway obstruction. Dr. Almeida, as we all know, is currently the program director for the Interventional Pulmonology Fellowship at the Cleveland Clinic Respiratory Institute. Welcome, Francisco, and let's dive into the topic. Thank you so much for agreeing to join us today.
No, thank you, Avi, for inviting me. It's a privilege to be here talking about this interesting topic.
Perfect. So we all know that electrosurgery plays an integral role in the management of malignant central airway obstruction. And we know that in terms of contact electrocautery, we have various devices at our disposal. We have the Bowie, we have the electrocautery knife, the electrocautery snare, which we'll talk about today, and some newer devices such as the Coag, which is marketed by one of the companies. So when you are deciding about using electrocautery snare for patients, is there a specific lesion characteristic or a type in which you use this as a go-to tool when you're managing these patients with central airway obstruction?
Yeah, so I think as the literature says, the more appropriate lesion to use are the polypoids or pedunculated lesions. But I don't necessarily use a snare only for those lesions. And on the flip side, and we'll talk maybe later depending on your questions, I don't necessarily use a snare for every pedunculated lesion. But in any event, those are the ideal lesions. But sometimes, as a way of doing a multimodality approach, some really large lesions, sometimes I would use the snare to start getting pieces out of it. So sometimes the lesion is so large and the base is so broad, but it's so irregular that sometimes you can grab relatively large pieces, not necessarily the entire thing, as to open your view or create more space to work. So sometimes I use as an initial tool for some of those lesions. And obviously it's hard to describe exactly how those lesions look on a podcast, but right. I think the audience who does this can have an idea of what I'm talking about.
Right. So, if you see like a pedunculated lesion, let's say with a narrow base or even with a large base, and you are, doing an intervention in these patients, is this your go-to tool, or do you start by using some other modality to achieve hemostasis, or do you use the snare to try to resect the base off with cautery or coagulation?
Yeah, so I think it depends on the size of the lesion. Sometimes there's these pedunculated lesions that is really small, and I've seen people use snares for those, and sometimes just a simple plain forceps biopsy, you can remove it. When it's something that a simple plain for biopsy can't remove it, or if the base is not really small, because sometimes there are these pedunculated lesions that my forceps won't be able to remove the whole thing, but the base is so slim that sometimes I can just kind of biopsy that base and really dislodge the lesion altogether. So I may not need snare. But for the majority of pedunculated or polypoid lesions that the base is not so broad that I can get my snare all around, I would say yes, the snare is my to-go device for those lesions, but not necessarily the only device.
Of course. Yeah, that's the beauty of multimodal approach. And then, in my practice, like when I have sometimes broad-based lesions, as you have mentioned, I will use it to at least try to shave off, some of the top, though it's hard to form a grip around it. Have you done that, or you do that frequently? Well, it's like a left main stem region that's near completely obstructing, and it's difficult to bypass with the scope itself. Try to grab that and at least try to shave it off as much as possible.
Yeah, so I use that sometimes. As you mentioned, and I mentioned before as well, is it can, I like the term they use, shave off. It can open a little bit of space and improve your view. And sometimes as you shave that off with the with the snare, you can also sort of coagulate the bass, which may decrease a little bit of the bleeding and help your work around that. But again, it depends on the lesion. I like sometimes my assistants complain when they look after the procedure is done that I have so many things around the field. I have the snare, I have the cryo, I have the APC, and sometimes I may have the laser on top of that. And aside from the rigid, so there's so many tools. So sometimes is a trial and error thing as well. Sometimes you start doing one thing, oh, this is not working, so you move along. But as I mentioned, I think the shaving off is something that I use. But I wouldn't say that for that lesion that is entirely obstructing and I don't know what's behind and I can only see a little sliver of opening and the base is really broad. I wouldn't say that the snare is a tool that I would think at first to use in those cases. But
right,
depending on what I see, I may use it to start shaving off the lesion as much as possible and work my way through creating a space to work with.
Right. It's funny you say that, do you need any more? I recently had a case where I think I had every single tool available out. And the staff was asking me if I need anything else because I think there was nothing left from the APC to the snare to the Bowie, and as you said, we go through multiple of them and see what works. So as you mentioned about the coagulation, so when you're using a snare, I use one of the RB devices and there's a cut option, there's the Coag option. So when do you choose one versus the other if you think that this lesion is the right lesion for to use electrocautery snare per se?
Yeah, so I mentioned coagulation, but I that's a great question. I didn't mean necessarily using the coagulation setting, because to be honest, I've been using snares for over a decade, and I don't remember if I ever used a coagulation setting, or let me rephrase that. I probably have used it once or twice, and I wasn't very impressed with the way it cut the lesion. So I use virtually, and is already preset on our machines for cut. We just set the cut. The option is already there. And that's what I use virtually 100% of the times. And, one may wonder, why don't you use a coagulation? Because it may coagulate better as you cut. And honestly, I think as I recall, the couple of cases, once or twice that I used the coagulation setting, it didn't cut as well. And I wasn't that impressed with the coagulation that was provided. So I think just having the cut setting is what I use, almost 100%, as I mentioned. And it cauterizes pretty well as you cut. In most cases, there are going to be cases that you cut and then there's a lot of bleeding afterwards. So those cases do occur. So, but I think the cutting is so much better that I don't even waste my time. And a lot of these cases, not all, but a lot of these cases, you have a rigid end, and we are prepared to deal with any bleeding that may occur after we cut these lesions. And that is, I think, one important message for people who are starting off, for people who are experienced as well, I guess, and maybe just want to hear another opinion or somebody different thought or confirm what they do, is that after we cut these lesions, you have to be ready to act immediately, because sometimes bleeding may happen, and I think that's something very important. So as we mentioned, we have all those tools ready. So generally, when I do a snare, I often have my APC ready, or I may have a Fogarty balloon or something, depending on the situation. Or I have my rigid really nearby to, if I think I'm going to cut the base, to advance the rigid and block, tamponade that area. So you need to be ready for bleeding that may come after you cut the lesion, because it's not overwhelmingly common, but it does happen.
Well, I think that's a very good point. Something that where we should be prepared. I mean, be that be balloon. I usually don't have a balloon, or if it's a more central lesion, like the tracheal lesion, then advance the rigid to be able to tamponade. But I think that's a very important point that you make. And as you said, I mean, what we gain in cut, we lose some of it in coagulation. So especially a very vascular lesion, may bleed sometimes. If I mean, it has happened to me a couple of times where it did do bleed, and we should be prepared. Sometimes we'll have either a contact cautery or APC, which is my go-to tool. So that's a very good point. So if you're using the cut settings, do you use like a preset? Because I know some of the machines have these EndoCut Q settings, or is there specific power and settings that you start at on your machine, just for the listeners, who are just starting off and are not really sure how to use the cut function on the Electrocautery Snare?
Yeah, so we have been using for many years the ConeMad Beamer device, and we already have it preset for 20 watts. And the majority of times that's all we use. Sometimes I go up to 30. We just acquired recently the herb machine that has APC, cautery, and the cryo kind of all together. And we may be transitioning entirely to that machine because of support, I believe, but I don't know the details. So for the ConeMad, it's preset at 20 watts, and for the herb machine is already preset there at the 3 watts with EndoCut based on their company tool. And I use that since we got the machine recently. I haven't used it that often, but I have used it a couple of times already. And it seems more powerful, which there's good and bad about that, right? Because more powerful, there may be more risk of collateral damage. So that's important to have the snare in position around the lesion, not loose, so you're not, often you can't see the other side, depending on the size of the lesion. So trying to have it as around and tight around the lesion as much as possible, not to provoke any collateral damage of areas that you're not seeing, especially with, I guess, the herb machine. At least that was my early experience. It may not hold true as I use it more, but I did like it, the cut. And that's kind of what we've been using, or at least what I'm using right now. And my colleagues may use slightly different. But I know that machine, the herb machine, is set already at 3 watts with EndoCut, like from the start. And
then we have the ability to adjust the EndoCut settings. And I mean, as you said, I mean, they're set for more cutting than coagulation. And I think as you go away from the settings like 1 to 4, it balances the cutting ability with the coagulation. But they do say, I was talking to one of the reps recently, and they talked about that too, where you can you keep the foot on the pedal, and then you can cut through, and you can see basically adjust that based upon how it's cutting or not cutting.
Correct.
So I mean, that's
talking about that. I think is important to say that sometimes, it doesn't cut perfectly. It doesn't cut well. So you need to adjust that setting, as I mentioned. Yeah.
Right. And so, I mean, I was talking about not working. So I recently had a case of a LMB lesion, very hard lesion, but we're still waiting on the pathology of that. But it was completely obstructing the LMB originating from the lower lobe. And I was trying to use the snare, and it was actually, as much as I tried, and I tried different EndoCut settings, it just would not cut the lesion. I mean, maybe based upon the characteristic of the lesion, on rapid onsite told me there are some spindle cells, and again, we're still waiting to see what it shows in terms of final pathology. So what are the potential pitfalls where you think the snare may not work? And is there some adjustments in the settings that we could make to try to see if it cuts better, or would you just then use alternative route? And what may those be?
Yeah, that's a great point. I mean, those are not common events, but they do happen. And I think, as you said, based on the lesion, whether it has less water or fluid or is more fatty, those are more difficult to cut sometimes if there's any of those situations. And it's funny that you mentioned, because several years ago, I had a case that I tried to cut, and it started to cut the lesion, but then it just wouldn't do anything. And then it wouldn't cut, and then we started to open the device, and it wouldn't open. So we were stuck there. We couldn't do anything. And I was, oh my goodness, I was already thinking ahead. I just thinking of myself, talk to the patient later today, saying, the case was great. The tumor is out. That's the good news. The bad news is that we had to take you to the OR to do that because we got stuck in there. But we eventually got that thing kind of dislodged. But when that happens, as we were talking before, you need to look at the plan B and see whether, if this is a lesion in the trachea or, in one of the main stem, that you may be able to try to get a rigid to try to core as much as you can. And some of those lesions, when that happens, is difficult to core with the rigid as well. So sometimes one thing that I have encountered in a few of these cases is I just change the location. So if I put my snare right at the base and it's just not cutting, so I try, let's try to cut, maybe the top half or the top 1/3. And sometimes that strategy helps cutting some of the pieces and then out, instead of trying to get the whole thing out at once. So that is a strategy that I have used. That's not a very common scenario, but when it happens, that's kind of the strategy that I use in those cases. I mean, there's based on no real evidence. It's just based on real time, experience. I don't know if we're ever going to be able to do a randomized controlled trial to define.
Yeah, probably not.
What we do for those situations, but that's kind of. And then you try the tools. Try to get a cryo and pull out some of that tumor. Or maybe try to devitalize some of the tumor, by applying APC or laser, and then coming back and then snaring most or some of the pieces. So it's a kind of a back and forth thing. I don't know if I clearly answered your concern, but I think this is a tough situation right. When it happens. But as we mentioned at the beginning, you have to try your other tools and see what works.
No, exactly. And I mean, the multimodal approach comes into play. I mean, as you mentioned, I also felt like my snare got stuck, and I was also starting to think ahead, but I was able to get the snare out and then tried cryo to pull, but it was originating from the left lower lobe, so it was difficult to do that. And then I switched to using the snare to cut up the top 1/3, and then use the hot forceps to try to get those out. So I think that stresses on the importance of the multimodal approach. But it's good to hear that we all have similar experiences. In terms of the type of snare, so is there a specific snare or type that you use based upon the airway in terms of size, or a specific company that you use?
Yeah, so we use this brand, Vanos, I believe, and I think it used to be Halyard, or I think one bought the other. I don't know the details. And that wasn't, I don't know much of the brands, to be honest. There was a decision that was made way before I came, and then we've been using. Nobody really complains about the quality of those devices, and we've been using them. So I really don't know if this is better or worse than any other particular brand. But they have been working well for us with minimal really issues or any. I don't recall any major issues with the devices. So for this particular company, they have 3 sizes, what they call the small, medium, and large, based on how much they open. And I really don't know the diameter of those. I can tell that the majority of cases, I use the small because I think these are devices that are used also in the GI world, and those lumens are larger and they can use larger devices. But most of the times I use this small, even for large tumors in the airways, and that will go around everything we need. Very rarely I I don't remember actually the last time I asked for a medium size snare. So most of the times I use the small size for this particular company, and they have different shapes. They have the round, they have hexagonal. There's another shape that I don't even know what the name of the shape is. It's kind of round, and then there's a part that is straight, mostly round, and then a straight portion to it. And I use mostly the round. I don't know if there's any particular benefit of one over the other. Sometimes when I ask for the round, we don't have it. And then, well, give me this or that. And I don't think I ever noticed any particular difference in how good or bad the outcome was based on the shape of the device. So I really don't know if there's any difference based on my experience. So as I said, I use mostly the round, and that has been working for me for virtually 100% of the cases. So I haven't really changed trying to use any of the other shapes. And I can tell you that we had all those three sizes, the small, medium, and large, and we stopped ordering the large because not me or any of my partners ever asked for the large, or if they asked before, they saw that didn't work, as I learned, kind of quote the hard way in the past. So we don't even have this large size. So we only have the small and the medium available in our Bronx suite.
Got it. Yeah, I've never used the Vernos, but we have the Snare Master, and again, I think those are shared with GI, so I tend to use a 15 millimeter. Not sure if the smaller is available, but that's when I ask for it, that's what I get, and that's what I end up using. So once you have snared this lesion out, like what is your usual extraction technique? Because that's something, especially if you're working in the central area, in the trachea or proximal mainstem bronchi, where the lesion can fall off. How do you prepare to extract these lesions while you're already thinking about snaring it?
Yeah, that's a great question. I think it depends. It depends on the size, and it depends on how hypoxemic the patient is or it isn't. And it depends on what airway you have in. So I have done these cases with a rigid, I have done these cases with an ET tube, and I have even done some of these cases with a LMA, a laryngeal mask airway in place. So I have used just simple suction, like putting a flexible scope in there and suctioning, or if I have a rigid, I could have put the rigid suction and suction that back. But some of those lesions that I have removed, that I have snared out, and the lesion is completely floating, I have had some lesions that they were so big that I couldn't pass it through the scope, the rigid scope. So I then have actually snared the lesion in two pieces so I can pass it through the rigid scope. Or, depending on the case, you just come back and block with either a rigid suction or a flexible scope suction inside the rigid scope or inside the ET tube, and come back with everything. I don't like necessarily that so much, because sometimes that suction is not as powerful to keep the lesion attached, and sometimes the lesion just, as you're coming out with everything, the lesion gets dislodged and it's stuck in the trachea or the vocal cords or the larynx. So one thing that I like to use often is a cryoprobe. Just put the cryoprobe, freeze it. I think that's the most guaranteed to come and not be dislodged, assuming that it fits into the airway that you have available, either the rigid or the ET tube. And sometimes I have actually used the actual snare. So I kind of use the snare to grab the lesion, and without using energy, just put enough pressure to hold it and bring it back. So try not to put another tool on the table. So It depends on, again, on the situation, but if it is not too large, just with suction. If it is larger, then either the snare or cryoprobe, and sometimes I have to come out and block with ET tube or rigid scope to remove the lesion. And when I do that, the end block removal, my preferred to-go devices are the cryoprobe or the actual snare without applying energy. So I know that I have a grip
Right.
of the lesion.
And I mean, I'm sure your assistant or your anesthesiologist is ready to, hand you the tools if you need to resecure the airway. Because I remember one case we had for tracheal lesion and we had to extubate and block. And it's important to be prepared to immediately either reinsert the rigid probe, or have a ET tube or whatever you need to resecure the airway if you are coming out and block.
Yeah, absolutely. And then I think it's very important. That's a great point that you bring, Avi. So depending on so let's say you snare the entire lesion, the base looks nicely cauterized. There's nothing else you're going to do with the case. Or even if there's some bleeding or whatever it is that is going on, it's very important to have that communication with the anesthesia team. So let's say we're all done. Okay, so look, we're going to come back and block. I'm going to come out and I'm going to be done with this rigid or with this procedure, with the scope, with the ET tube. So before I do this, the plan is X. And the plan is often, in our team is to put an LMA and then wake up the patient with an LMA. Or if the anesthesia team, for whatever reason, wants to put an ET tube back, they will be ready to either get another ET tube to be ready if there's any concern with timing of dislodging that lesion from the tip of your scope, coming out of the scope and getting that same ET tube, if there's any concern that we need to intubate right away because of oxygenation or whatever it is. So that point in time, your communication with the anesthesia team is extremely important. So, and throughout the case is very important, obviously, because we need to remember to tell them to cut down FiO2. I know that is something we didn't discuss, but I think it's important to say whenever you're going to use a snare, we generally cut down our FiO2 to less than 40%. As a general rule, I think anything less than 50% is probably fine. Probably even a little higher may be okay, but I would suggest that, keep it as low as possible. Below 50 is fine for, I think I've never seen any fire with 50 or below. So that is, that line of communication that you want to have with your anesthesia team throughout the case. And when removing the lesion is an especially important one because you need to plan especially if you're coming out en bloc, that communication is extremely important.
Right. And I mean, something that I've used more commonly like foreign bodies rather than, en bloc removals of lesions is, having a McGill around, because I think one or two cases where in fellowship where the object can get lost in the upper airway, rather the mouth or the oropharynx. So something always important to know where your McGill is, even if you don't physically have it available to extract that from the mouth. Yeah. Not that I would think it would be relevant in a lesion per se.
Yeah. Yeah, but no, that's a very important point. Yeah, absolutely, having that available. So that's a preparation before you come out. And sometimes if the lesion is too large, it's important to be ready for the lesion to end up being dislodged, around the vocal cords or something. Yeah, very important.
Absolutely, that's great. So you mentioned lowering the FiO2, below 40% ideally. Is there any other precautions that you take apart from having good communication and preparation in terms of using electrocautery snare, some things our listeners should be aware about or know or be prepared for?
And I think we discussed most of the important things. The FiO2, your communication, knowing your other tools to be ready. I think one thing that we didn't discuss, or maybe we did, I think we spoke about making sure you have that snare around the lesion and is tight before you start really using your energy. Remembering to the sheath of the snare to put that at the base of the lesion on the proximal side where you can see, to the base of the lesion as much as possible, but being careful not to be pushing that sheath against the normal airway. So pushing that against the base of the lesion and not normal airway necessarily. I think those are probably the only other point or points that we haven't discussed that I can think of. I mean, is there anything else that you think missed?
No, I think I agree. I mean, I think you pointed out a very important point of continuously visualizing the snare closing and not trying to cut the lesion by closing the snare, but rather using energy to cut the lesion so that we can get as much coagulation as possible while we continue to close that snare and cauterize that area. Any other comments? Any other pearls in terms of using electrocautery or electrosurgery, and specifically snare, for that our listeners can benefit in their practice?
Yeah, no, I think we discussed a lot. I can't really think of anything else here. Maybe the other point that could be important, I think snares work best in bigger airways, trachea and main stem bronchi, bronchus intermedius is a little bit more difficult when you working at the lobar, the segmental level, because those snares are not, as we mentioned before, even the small is kind of large for the airways. So those can be tough, especially if you're going to, the upper lobes to make that turn, that sheath is somewhat rigid. So it's a little bit more difficult. And sometimes when you're getting more distal, then you're talking about, if you're not really careful, you may start cauterizing really distal airway that you don't know what's out there. So you have to be careful with that. So those cases are not, in my opinion, great cases. But aside from that and what we have discussed so far, I can't think of anything else right now. I think this was great. We discussed a lot of things, about some ideas, and this was awesome.
No, this is great. I mean, this is, I'm sure, very helpful for me, and I'm sure very helpful and educational for our listeners. So thank you so much for joining us today, Francisco. This was another episode of...
Thank you. Yeah, thank you very much. Sorry for interrupting. Thank you very much. This was really great.
Perfect. This brings an end to another episode of the ABIP podcast. Please don't forget to subscribe to our YouTube channel and follow us on the Apple Podcast.